Hello and welcome to today's webinar. I'm Shelley Gunther, Clinical Marketing Manager at Clarius. Now, we continue to receive requests for educational content for physiotherapists, and many of those requests have been about today's topic. So we're very excited to be able to bring you this webinar titled POCUS for Pelvic Health, Enhancing Assessment and Treatment with Transabdominal Real-Time Ultrasound. You're among just shy of 2,200 people who registered for this popular session. So again, welcome everyone. It's been such a pleasure collaborating with Adrienne on this project, and we appreciate her willingness, enthusiasm, and passion in making this happen. Now, in a moment, she'll be joining us to share how she uses ultrasound in her physiotherapy practice. Now, quick housekeeping note, please use the Q&A icon at any time during today's session to ask questions, and we'll address them in the live session close to the top of the hour. I have the privilege of hosting today's event, and I'll be introducing sonographer Janae Smith in a little while as well. Janae's going to give us a live scanning demo after the presentation. Now, before we begin, I'd like to review a couple of papers I came across when putting together the abstract for this webinar. Now, this is just a really good overview of urinary incontinence from Stat Pearls, and it defines urinary incontinence and describes and differentiates the various types. The authors talk about just how prevalent this condition is in the United States. Approximately 13 million individuals are directly affected. So along with physical examination and a good clinical patient history, ultrasound is an important tool in the evaluation of post-void residual volumes in patients with suspected overflow incontinence. Treatment mentioned includes pelvic floor muscle training using ultrasound to guide the therapists and their patients. So for stress urinary incontinence, median cure rates are 59% at 12 months for women who use supervised pelvic floor muscle training, and 78% at 6 months for men that use pelvic floor muscle training. So this next paper is from the Department of Physical Therapists at Ariel University in Israel. And the author set out to study how different positions like lying, sitting, standing can affect pelvic floor muscle function in women with stress urinary incontinence. And they used transabdominal ultrasound for these assessments. The scanning technique was similar to what you're going to see today. The results of their study show that women with stress urinary incontinence have lower pelvic floor muscle function while standing or sitting, but not while lying down, in comparison to those without stress urinary incontinence. They're looking forward to using this information to better develop personalized treatments for their patients. So hopefully the research continues and more ultrasound techniques and protocols are developed to address this very common condition. So just a quick poll before I introduce our guest here. What do you perceive as the benefits of using ultrasound in your physiotherapy practice? And you can choose all that apply. Great, I'll just give a couple of more seconds here. 3, 2, 1. Excellent. So kind of across the board here, improved diagnostic accuracy, increased efficiency in treatment. That's really good. A couple of you aren't using ultrasound, so hopefully we're going to change that today. All right. Good. And now I'd like to introduce pelvic health physiotherapist Adrienne Sim. Adrienne's been a practicing physiotherapist since 2010 with a dedicated focus on pelvic health since completing her postgraduate certificate in continence and women's health at Curtin University in Australia in 2014. She integrates real-time ultrasound into her clinical practice and continuously evolves her approach in line with the emerging research. A passionate advocate for pelvic health education and knowledge translation, Adrienne contributes actively to the field through her work with the Canadian Society for Pelvic Medicine, serving on various committees and the board. She's been involved in multiple grant-funded initiatives and has presented her work in both locally and internationally. Adrienne currently practices in Langley, which is very close to Clarius headquarters in Canada here, and is networked with colleagues of Full Circle Physiotherapy. She will begin her PhD studies in the fall of 2025. Welcome, Adrienne. So nice to see you, and I will hand the presentation over to you now.
Thank you for the introduction, Shelley. So today we'll be covering transabdominal ultrasound imaging for pelvic health. So before I begin, I want to take a moment to acknowledge that I am presenting today as an uninvited settler on the traditional, ancestral, and unceded lands of the Coast Salish people, including the Kwantlen, Katzie, Matsqui, and Semiahmoo First Nations. I'm deeply grateful to live and work on this beautiful land, and I recognize the ongoing connection that these nations have to this territory. As someone committed to care and healing, I recognize my responsibility to continually learn, listen, and engage in meaningful ways that honor Indigenous presence and knowledge. So I'd also like to acknowledge my disclosures. I am receiving an honorarium from Clarius for today's webinar. I also practice as a fee-for-service physiotherapist, and I do benefit from professional referrals. And it's also important to recognize that my experiences and perspectives carry some bias. So my journey with ultrasound began during my physiotherapy training in Australia, where I was fortunate to receive an excellent introduction to pelvic health. And it was during that time that I first saw how ultrasound could be used for pelvic floor and core feedback. I remember being fascinated by how much we could learn by seeing that real-time feedback on the screen. Later, when I returned to Australia to complete my postgraduate training in pelvic health, I had the opportunity to explore ultrasound more deeply and integrate it into clinical practice. After moving back to Canada in 2014, I was really lucky to work in clinics where ultrasound was readily available, and since then it has become a core part of how I practice. I've also continued to grow my understanding by attending workshops and conferences such as those put on by the International Continence Society and International Urogynecological Association, where I've been privileged to learn from some of the leading researchers doing pelvic health ultrasound. So their work continues to inspire how I apply this technology in my own practice. So here's what we'll be covering today. So how to choose the right ultrasound equipment for pelvic floor and core imaging, understanding presets and how to obtain a clear, high quality image, exploring the scope and limitations of the transabdominal approach, assessing the pelvic floor function using both transverse and sagittal views, assessing inter-recti distance, imaging techniques for the transverse abdominis and how this fits into core assessment, and finally, the role of ultrasound in evaluating urinary bladder function. All right, so one of the exciting developments in recent years has been the increased accessibility of handheld ultrasound devices like those from Clarius for physiotherapists working in clinical settings. So these devices are cost-effective, they're compact and easy to use, making them ideal for clinics with limited space or for assessments that require different patient positions. So the cordless design also allows for a smoother workflow and more comfortable interaction with clients compared to a traditional cart-based or corded system. So in pelvic health, 2 Clarius probes are commonly used. The first is a high-frequency linear probe like the L7 shown on the left here, which provides excellent resolution for superficial structures like the abdominal wall. And then the C3 probe on the right here, a low-frequency curvilinear probe, which offers greater depth penetration, making it ideal for deeper pelvic structures or when working with clients who have a larger abdominal circumference or higher body mass index. So for today's presentation, we will be using the C3 probe. So the curvilinear design and deeper imaging capabilities make it well suited for the transabdominal approach, which is our focus for this session today. So let's talk a little bit about presets here and image optimization when using ultrasound for pelvic floor and core assessment. So commonly used presets include the bladder, abdominal, superficial, and pelvic floor presets, depending on the depth and focus of the scan. Once the preset is selected, you'll need to make some simple adjustments with the depth, which is like zooming in or out to center the area of interest, and also with the gain that affects the brightness of the image. So we're aiming for a balanced view that's not too bright and not too dark. A standardized bladder filling protocol is often recommended to improve consistency and image clarity. So this typically involves asking the patient to void their bladder about an hour before the scan, then drinking approximately 1 to 2 cups of water and refraining from voiding until after the assessment. So unlike other types of abdominal ultrasound, such as those for diagnostic medical imaging or fetal imaging, where a full bladder is necessary, we don't actually want the bladder to be overfilled in this context. So an overfull bladder can actually interfere with the assessment by increasing the resting activity of the pelvic floor muscles, which may lead to an inaccurate interpretation. Finally, not to underestimate the importance of patient positioning and probe handling. So we want to ensure patient comfort. So getting the patient into supported position with pillows, or if they're in standing, having a chair in front of them to limit the amount of sway, along with gentle and consistent probe contact, which will help get the clearest and most meaningful images possible. So practice in probe handling and real-time imaging is definitely key. So before we dive in further, I want to highlight an important article by Smith and colleagues, which discusses the use of point-of-care ultrasound in pelvic health physiotherapy. So this article outlines the scope of practice as well as key considerations around education, competency, and governance when integrating ultrasound into clinical care. So it's important to note that while today's webinar provides an introduction or high-level overview, further education and hands-on training are strongly recommended to develop true competency in the clinical use of ultrasound. And also recognizing that we are using ultrasound primarily today for biofeedback purposes and not diagnostic medical imaging. The article also discusses broader applications, including transperineal imaging. However, today's session will focus specifically on the transabdominal approach, which is a versatile and accessible starting point for many clinicians. So let's now take a closer look at the transabdominal approach, its advantages, limitations, and how it can meaningfully support pelvic health physiotherapy in practice. So some of the advantages include that it's completely non-invasive, so the patient remains clothed, which may increase comfort and accessibility to care. It's especially valuable when internal exams are not appropriate or desired by the client. So whether this is due to trauma, discomfort, or medical contraindications, while it doesn't replace the information gained through an internal assessment, it still offers objective insights that can help to guide care. For clinicians who do not perform internal exams, transabdominal ultrasound offers a valuable tool to visualize and assess pelvic floor and core strategies. We can also back up what we're observing through palpation or functional testing with real-time visual imaging, which adds clarity and credibility to our assessments. Assessments are possible in a range of different positions, including supine, crook lie, sitting, standing, and even on hands and knees, so making it functionally relevant and adaptable. There's also strong reliability evidence, so good inter and intra-rater reliability has been demonstrated for bladder-based displacement during a pelvic floor contraction, and strong intra-rater reliability during functional testing, like the straight leg raise. Ultrasound also serves as a valid form of biofeedback, so it helps to guide pelvic floor muscle training, which we know is a first-line treatment for many pelvic floor conditions. Patient education can be enhanced with ultrasound, so seeing their own anatomy in motion on the screen can help patients connect with their body, understand instructions, and feel empowered in their treatment. The visual feedback helps to improve motor learning and helps clients engage more effectively and potentially progress more quickly. We can decrease barriers and increase motivation with patients by making what is normally invisible to them visible and giving them tangible sense of progress and control. It also allows us to measure bladder volume, post-void residuals, and even work with bladder retraining in real time. So it has a lot of benefits. Some of the limitations, though, include that in a transabdominal approach, there are no fixed bony landmarks, which makes this standardized probe placement more difficult. This method does not assess the resting tone or strength of the pelvic floor muscles, so important to note there. Caution is needed when movement on the screen may sometimes reflect abdominal wall activity or probe motion, so not true pelvic floor activation. and the standardized bladder filling protocol is recommended to optimize imaging. However, this can be difficult for some patients to follow or remember. So overall, the transabdominal approach is a clinically supported, patient-centered, and highly versatile way to support both assessment and treatment, enhancing access, understanding, and outcomes in pelvic health physiotherapy. So now we'll move into pelvic floor assessment using ultrasound. So I'd like to begin by highlighting the 2021 ICS standardized assessment paper, which provides consensus-based terminology for evaluating pelvic floor muscle function and dysfunction. This report suggests clinical practice and includes guidance on the use of transabdominal ultrasound. So I do have a pelvic model here just to, if people aren't familiar with where the pelvic floor is. So this is the pelvis here, and we'll see at the base of the pelvis, if I can orient it correctly, you'll see the levator ani. So that comes from the pubic bone all the way to the tailbone and then out into the hip muscles at the side. So when we are imaging the bladder and we're looking at the bladder base, this is the translation of the pelvic floor that we're seeing on the screen there. So for this assessment, we use a convex transducer placed suprapubically. So you can see that in the picture here on the slide. So when oriented transversely, we can assess the bladder base symmetry and displacement. So in the ICS paper, it outlines key parameters observed in both the transverse and mid-sagittal planes during different pelvic floor muscle activity states. So at rest, during contraction, and with a bearing down. So at rest, we assess bladder base symmetry. So asymmetry may indicate unilateral changes in tone, improper probe positioning, or asymmetry in passive support structures. During a pelvic floor muscle contraction, elevation of the bladder base in an upward direction is the expected response. If we're seeing descent or lowering of the bladder base, it may reflect dysfunctional recruitment patterns. We can make observations about the quality of the relaxation, whether it is non-relaxing, delayed, partial, or complete, back to its resting position. And with bearing down, which is a prolonged increase in intra-abdominal pressure, we can observe the displacement pattern of the bladder base, which can offer insight into load management and pelvic floor muscle coordination. So typically, radiological convention and research orients the probe marker to the patient's right side, which corresponds to the left side of the screen. However, in clinical, dynamic, or functional assessments, we orient the probe marker to the patient's left so that it matches the marker on the screen and reflects what the patient is feeling and seeing. So the goal is to obtain a clear image of the bladder base. So you'll need to adjust the probe angle and pressure to maintain consistent placement and image clarity. A few considerations are that consistency of the probe placement relative to the bony pelvis. During functional activities or pelvic floor contractions, abdominal muscle activity or increased intra-abdominal pressure can cause the probe to shift outward or slide. So this outward motion can mimic bladder base descent by increasing the distance between the bladder base and the probe. So it's important to stabilize the transducer with gentle inward pressure. Then when interpreting movement, we need to keep in mind that this assessment can be influenced by multiple factors, including the amount of bladder filling, transducer position, the measurement site, and the patient instructions. So maintaining accuracy requires a balance of technical skill and clinical judgment, especially in dynamic assessments. So we'll go over transabdominal ultrasound for the pelvic floor and the transverse plane in this video clip. So for this view, as you can see in the picture, the transducer is placed transversely across the midline in the lower abdomen in the suprapubic region, with the probe angled to about 60 degrees from the vertical, aiming it towards the bladder base. So we can see here, I'm just fishtailing the probe a little bit to get a good bladder view. And we can observe the symmetry of the bladder base here, which looks fairly symmetrical. Then we can ask the patient to contract the pelvic floor, and a normal response during a pelvic floor contraction is that bladder base elevation that we just observed, and then followed by the relaxation. Here we're asking the patient to do a sustained hold or an endurance hold. So we can observe the symmetry here. So we're seeing a little bit of the left side elevated more than the right, and then followed by a relaxation or a let go here back to the resting position. So it's important to note again that the movement does not equate to muscle strength. So we're going to follow this up here by asking the client or patient to do some quicker coordinated contractions, so a quicker lift and let go, so we can make inferences about their ability to voluntarily control their pelvic floor. This next clip is demonstrating the difference between a symmetrical and an asymmetrical contraction. So on the left side of the screen here, we'll see a symmetrical lift of that bladder base and a let go back down. And we can see a bit of a delayed let go there as well, compared to an asymmetrical lift on the right side of the screen here, where we can see the right side of the bladder base elevating more than the left. So additionally, we can make observations with the client in different positions and look at different functions of the pelvic floor in these positions, including those endurance holds or coordinated contractions, and while doing functional tasks such as a crunch or active straight leg raise with or without a pelvic floor muscle contraction. So in this next video clip, we have the patient in standing for a dynamic functional assessment where we can observe bladder-based movement here. So to stabilize the probe in standing, we position a hand behind the patient's back or on the lower kind of sacral area to minimize sway, or you can also get a chair in front of them so that they can hold on to it. So in this case, the angle of the transducer is adjusted until we have a clear image of the bladder base here. And then we get the patient to do a contraction and we can see a lift of that bladder base and a little bit of movement of the abdominal wall happening as well. And then we're going to get the client to do a sustained hold. So again, we're observing a little bit of that left side elevation, a little bit more than the right as well, that corresponded into the crook lie position. And then that letting go relaxation here. Then we're going to have, again, looking at those quicker coordinated contractions. So a faster lift and let go. And again, we can see a little bit of abdominal movement and the probe sliding here. So again, just making sure to maintain that contact and gentle pressure there so that it doesn't slide. So when orienting the probe longitudinally or in the mid-sagittal plane, we can also observe bladder-based displacement with a pelvic floor contraction or bearing down here. So for a sagittal plane ultrasound imaging of the bladder base, the ultrasound transducer is placed in the mid-sagittal orientation superior to the pubic symphysis of the lower abdomen. So you can see that in the photo here. The angle of the transducer is manipulated until it points posterior and inferior to the pubic symphysis. So this is towards the posterior inferior region of the bladder base, allowing for a clear image of the bladder. The marker of the transducer, which indicates the left side of the screen, should be oriented towards the patient's head. So in this video, we will observe the sagittal view. So you'll see here that the probe is rotated, again, with the marker towards the patient's head, which indicates the left side of the screen. And then we get the client to do a pelvic floor contraction. And we can see, again, a lift of that bladder base and a let go back down to the original resting position. So in this view, we're able to look at a different view of bladder-based displacement. So sometimes when we're having difficulties imaging a lift in the transverse view, we can sometimes pick it up better in the sagittal view. So next we'll take a look at inter-recti distance, or IRD. So this refers to the width of the linea alba, which is the connective tissue between the paired rectus abdominis muscles, and is often measured for concerns related or around diastasis recti. So research and normative values are evolving in this area, and I would encourage you to consult the emerging research, which is outside the scope of today's webinar. So ultrasound is widely recognized as the gold standard for assessing IRD, thanks to its strong validity and excellent intra and inter-rater reliability. It's also more sensitive to subtle changes than palpation, making it ideal for both assessment and ongoing monitoring. So common measurement points include at the umbilicus, 3 and 5 centimeters above the umbilicus, and 3 centimeters below the umbilicus. So these standardized locations provide a more comprehensive view of the abdominal wall function and support consistency in repeat measurements. IRD is typically assessed in two conditions, so at rest with abdominal muscles relaxed, and then during an abdominal activation, such as a gentle head lift or a crunch, with or without specific cueing. So using ultrasound to measure IRD is a valuable component of treatment planning, allowing us to really track progress over time and tailor interventions to the individual. So in this video, we'll be scanning for the inter-recti distance. So we start by scanning to the right of the patient's abdomen, getting the right rectus abdominis in view here, and then looking at where the head of the rectus connects to the linea alba, panning through the midline and then over to the left rectus abdominis. So then we're coming back to the center so that we can get both of those recti in view, along with where they attach to the linea alba. And then also get a clear image of the linea alba. We may need to adjust the depth sometimes, but then we freeze the image. We can pull out the calipers, and then we can measure from one recti head to the other. And then the measurement shows up on the upper left side of the screen there. So further to at-rest assessment, we can then go into an abdominal activation and observe what happens to the linea alba on abdominal activation. So in this case, we're getting the patient to do a head lift. So we can see the inter-recti distance narrowing here. Again, we can freeze the image, pull out our calipers, remeasure here, and also make some observations about the behavior of the linea alba. And then in the last part of this inter-recti assessment, we can do another assessment where we use a pre-activation cue to make another observation of what happens to the inter-recti distance and the behavior of the linea alba again. So we unfreeze the image, come back to the midline, and in this case, we're going to cue the patient for a pelvic floor contraction before they do a head lift, and then we can see as the patient lifts that there is a little bit of a narrowing and again a change in what happens with the linea alba there. So of note with this type of approach to measure inter-recti distance is pressure. Too much pressure could deform the abdominal wall in linea alba, and too little pressure will not allow for adequate contact with the skin surface, which decreases the ability to visualize the linea alba. The inter-recti distance can sometimes be difficult to image, especially in cases where the inter-recti distance is wider than the ultrasound probe, or on activation when the recti are actually pushing the probe out and there is a loss of contact with the skin in the midline. So now we'll move on to ultrasound imaging of the lateral abdominal wall. So in the transverse plane, ultrasound gives us a layered view of 3 primary abdominal muscles separated by bright hyperechoic fascial lines, including the external oblique, the internal oblique, and the transverse abdominis, which is the deepest layer. So we can image at various points throughout the abdominal wall. So in this photo here on the slide, we're imaging in the lower portion of the abdominal wall, but we can also image in the middle or upper regions. And this makes ultrasound a really valuable tool in managing musculoskeletal dysfunction involving the abdominal wall, including some types of low back pain and pelvic pain. Typically, this region is imaged with the client in a crook lying position, so supine with the knees bent. But one of ultrasound's greatest advantages is its flexibility. So we can actually assess the abdominal wall during functional tasks and in different postures and positions, including sitting, standing, sitting in a chair, on an exercise ball, or on hands and knees. So a key clinical use is assessing the resting position and activation and the lateral slide of the transverse abdominis, especially during motor control exercises like an abdominal draw-in. So this gives real-time visual feedback, which is a really powerful tool for both therapists and clients. So importantly, this is one of the only clinical methods available to visualize the morphology and behavior of the transverse abdominis in action. This feedback is especially validating for clients who aren't sure if their core is activating correctly, and it helps to bridge the gap between sensation and function for patients. So ultrasound offers a unique way to observe, teach, and reinforce core muscle engagement, which can improve clinical reasoning, strengthen patient understanding, and support targeted interventions. So in this video, we'll be imaging the lateral abdominal wall in the transverse plane. So we'll see that the probe is positioned transversely with the marker oriented to the patient's left that corresponds to the left side of the screen. The probe is then moved laterally until the 3 layers of abdominal wall come into view. So the deepest layer is the transversus, middle layer is the internal oblique, and then we have the external oblique above that. We're going to cue the patient for a core contraction. And in this video, you'll notice a big slide of the probe and a strong contraction of that internal oblique. So a reminder of how probe stability is key during dynamic assessment. In the next part of this video, we cue for more of a gentle connection or an isolated transverse abdominis contraction, and you can see less probe movement, a nice lateral slide of the transverse abdominis with less internal oblique involvement. So when using this for biofeedback, it can be helpful to keep the probe marker towards the patient's left, whether you're on the left side or right side of the abdomen, so that the posterior aspect of the lateral abdominal wall appears on the image side being assessed. So this makes it easier to observe the lateral sliding of the transverse abdominis during abdominal activation, which is an important visual for both the clinician and the patient. So now we'll take a look at bladder volumes and how we can use ultrasound to support both assessment and education. So when working with bladder volumes, there is a bladder preset for measuring pre-void or post-void residuals, which is also known as PVR. There are 2 main clinical applications here. So one for urinary urgency. So ultrasound can help patients conceptualize their bladder sensations more accurately. So many people with urgency symptoms may feel the need to void when their bladder is only partially full. So by visualizing their bladder volume in real time, we can actually support education on normal bladder filling and micturition patterns and begin to retrain their perception of urgency. Imaging post-void residual is a helpful non-invasive way to assess whether the bladder is effectively emptying. It can be especially useful in cases of incomplete voiding or urinary hesitancy, or as Shelley mentioned, overflow incontinence, and can help to inform referrals or multidisciplinary care when needed. So these applications offer meaningful, immediate feedback and are a great way to involve the patient in their own kind of care planning. So in this video, I'm using the Clarius AI function for the first time to measure bladder volume. So we start by placing the probe on the lower abdomen in the transverse plane with the probe marker to the left of the patient. And the probe is adjusted till we get a full clear image of the bladder. And you can see the AI function pull up here with the yellow inside the bladder walls. So we can freeze the image and then adjust the calipers as needed. We then capture the image. And then we're going to rotate the probe in the sagittal plane and unfreeze the image. Then again, you can see the AI function fill the bladder. We're going to freeze the image, the calipers come back out, and then capture the image, and then the bladder volume is then calculated and displayed automatically in the top left corner of the screen. So this approach is really quick, it's reproducible, and it adds a lot of value to both the clinical assessment and patient education. So thank you all so much for joining me today. We've covered a lot of ground in a short amount of time, from selecting appropriate ultrasound equipment and understanding presets to imaging techniques for pelvic floor and abdominal wall assessment using the transabdominal approach. We've explored how ultrasound enhances clinical validity and patient education, offers non-invasive assessment options, especially for those unable or unwilling to undergo internal exams. It supports biofeedback, motor learning, and core engagement, and provides a meaningful way to integrate imaging into everyday clinical practice. So while today's session focused on foundational concepts, it's important to remember that competent and confident use of ultrasound does require continued education, practice, and mentorship. So I strongly encourage you to explore further training opportunities and engage with a growing body of research in this area. Special thank you to Clarius for supporting today's session, and to all of you for your thoughtful attention and commitment to advancing pelvic health care. I really hope today offered some valuable insights and sparked some new ideas for how you might integrate ultrasound into your own clinical toolkit. And one plug here, I'm really excited to share that PFD Week 2025, hosted by the American Urogynecologic Society, AUGS, in collaboration with the Canadian Society for Pelvic Medicine, CSPM, is happening in October from the 14th to the 17th in beautiful BC here, Vancouver, BC. So this year's conference will include a physio forum with a special focus on advanced clinical skills, and we're offering an intermediate hands-on ultrasound station featuring transperineal ultrasound training, which is a great opportunity to deepen your skills and clinical confidence. So we're really thrilled to have Clarius on site as well, generously providing several portable units for hands-on learning. So if you're not already a CSPM member, now is a great time to join. CSPM members receive discounted registration for PFD Week, so you can scan the QR code on this slide to visit the CSPM website and sign up there. So I hope you'll mark your calendars. Registration opens in 2 weeks on July the 1st, and hope to see you in Vancouver this October. Thank you and take care.
Thanks, Adrienne. Yeah, no better training than hands-on. So yes, people, if you're anywhere near the Lower Mainland in the Vancouver area, just try to attend that. I know it'll be great. Thanks, Adrienne. Okay, we're going to hand things over to Janae for a quick live demo. So I think, Janae, you're going to start with the C3 scanner just to show how to scan the bladder and a little bit about the Bladder AI and how slick that is.
Yes. Yes, I am using the C3 scanner, and I've selected the bladder preset. I've got my patient in the crook lie position, and we're going to start in a transverse probe orientation in the lower pelvic area. And I'm going to angle down towards the patient's pubic bone to bring the bladder into view here. So we can adjust the gain. You can turn the auto gain on or off. I like to have it off when I'm scanning the bladder because I find the near field, it's nice to clear out some of the artifact. And depending on your patient's body habitus too, sometimes you have to, it's nice to be able to adjust those different segments of your image. So we can see a nice view of the bladder here. And when I've got the bladder in the largest aspect, I'll turn on the AI, and we're going to take a bladder volume calculation. So we'll turn on the AI by selecting the AI icon here on the left-hand side of the screen, and we'll select bladder volume. And right away, we can see that a green masking overlay indicates the bladder for us. And we can also adjust that masking overlay by selecting the B icon and selecting the AI opacity. If we want to increase that opacity, we can drag your finger on the screen to the left. And if you want to increase it, you can drag it to the right. And when I'm happy with the amount of opacity, I can go ahead and freeze the image. And the calipers have been placed for me. They look in perfect position here, but if I wanted to adjust them manually, I can simply drag my finger on the screen. So it's got the two measurements displayed on the top left-hand corner of the screen. We'll save those. And then I'm going to go ahead and rotate my probe here 90 degrees into the sagittal orientation. And here it's highlighted the bladder in its sagittal orientation. When I'm happy with the image, I can go ahead and freeze. And again, it's placed the calipers for me. And on the top left-hand corner of the screen, you can see that it's calculated the volume and displayed it for me. So we'll save that. So that makes it very easy and quick to show the bladder volumes.
Hey, Janae, there was a question in the chat about the orientation, and I know, Adrienne, we had chatted about that before. Like in your presentation, you had mentioned that typical like diagnostic imaging, we scan with the indicator to the patient's
right,
or sorry, yeah, to the right, and yes. But because the patient is facing the screen, because you want them to face the screen so you can explain how to engage their muscles, it's reversed. Is that correct?
Yes, yeah, I understand that.
Yeah, so in the case of bladder volume measurements, it's not as important. But if we're talking about like using it for biofeedback purposes, where we're engaging the client in the session, you know, to orient to what's on the screen. Again, if you're imaging your left side and you're looking at the right side of the screen, it's kind of counterintuitive and hard for your brain to conceptualize that. So if we're again, you know, having the left side or the marker of the probe and mimicking the left side of the screen, it can make it easier for patients to understand.
Great. Yeah, and as you know, Janae and I are sonographers, so we're backwards to all of that. So
that's right.
So yeah, but good. Yeah, important point. Somebody had asked us about that, and then there was another question about. I think it was where is how do you know which is the base of the bladder?
Okay.
Is there? I'm sorry, I'm just
this
looking.
This would be the base of the bladder
again.
Here at the bottom.
Excellent. Yeah. Okay. Do you have your marker there? Sorry, I didn't see it.
Yeah, I did.
Okay, so along there.
Yeah. There. Yeah. Okay. That's where you would see the urine jets and all that.
And then the elevation if there was some. Okay, cool.
Yeah. Did you want to try a pelvic floor contraction? See if we can. Anna, do you want to try and engage that pelvic floor for us? Yeah, you can see that visible lift there on the pelvic floor here, and relax. And try one more lift. A little bit more lift on this patient's right hand. Would be the right hand side. And relax. Good. Excellent. Yeah. We can have a look at the inter-recti distance. I'm going to change my preset on this one to superficial. And then we'll come up a little higher. I'm going to start just a little bit above the patient's belly button or umbilicus. And you said here you want to be careful with your pressure on this one, not to compress that linea alba. And we can see here the two rectus abdominis muscles on the sides, the right and the left. And then here is the linea alba. So if we wanted to measure that linea alba distance, we'll freeze the image. We'll bring up our calipers from one side to the other, 9.9 millimeters. And then we can also have a look with a contraction. So I'll get you to engage those muscles, tighten and relax. And tighten your muscles and relax. Good. All right. And then you can also have a look at the lateral abdominal muscle here. So we'll increase our depth. We'll stay on the same preset. And so we're still in a transverse orientation here. Coming out of depth. And here you can see those three muscles come into view there. So
maybe
Adrienne,
you can point those out. Yeah, there was a question in the chat about pointing out which one is which.
Okay, yeah, so this is the transverse, and we've got the internal oblique and the external oblique here most superficially. And then if you want to do a pelvic contraction there. Good. And freeze that. Anything that you wanted to add, Adrienne or Shelley, with any of those areas?
So in this particular view with the lateral abdominal wall too, we can kind of see again whether or not the transverse abdominis is on already at rest, so which can limit the amount of that lateral slide or glide that we observe. So in this case, it looks like it may already be on a little bit because it's not, again, kind of coming out towards the top of the internal oblique. So it's quite a ways back to start already before she starts engaging. So sometimes it can be helpful to get the patient to do some deep breathing to kind of get the transverse abdominis to let go or relax a little bit. And this can be often a quite common presentation in people who have back pain or things like that, where they're actually guarding. So it can be a good feedback tool to get them to let go of their transverse abdominis and abdominal wall, and then show them how to activate and let go. So moving through that movement a little bit more.
Okay. Great. Anything else that you wanted to have me to have a look at, Shelley? Any other questions that are relevant?
We have a couple of minutes. Why don't you connect the linear scanner just so people can have a look at that as well, just because that is an option for imaging the abdominal wall muscles. And while you're doing that, I'll have a look through the questions here.
Yeah, we can have a look at that inter-recti distance with the L15.
Yeah. Yeah, and again, just keeping in mind that you're going to have the L15 is going to be, or the L7, as Adrienne showed, is going to be, you're going to have less penetration into the abdomen. So if you are looking at deeper structures, it's probably not the scanner that you want. But if you're doing more shoulder assessments, knee assessments, things like that, then this might be useful for you.
Right. Give it a second here to connect. There we go. So this is in that same position, just above the umbilicus. And we can see the rectus abdominis muscles on the side. And actually a bit more of a clear image of the linea alba with this one. Do you agree, Adrienne? Yeah. And so we'll freeze here and take a measurement. So you can see the two probes, the different image that you can see definitely clears up that near field with the L15 a little bit nicer. I think we can scan all the way up. So this is getting a little bit closer to the ribs here. So the linea alba decreases in size, and then we'll scan all the way down towards the belly button. It widens out a little bit there. And I'm really putting a light pressure on that,
Okay.
not to compress that linea alba.
I wouldn't have thought that pressure would make that much of a difference, but it makes sense.
Yeah. Yeah. All right. I'll hand it back to you.
Good. Okay. Thank you, Janae. That was
Thank
awesome.
you.
All right. So just before we open the floor to live questions, here's another quick poll. So we'd love to help everybody continue their journey into bringing handheld ultrasound into your practice. So please complete this and let us know if we can provide any further information. And you can click on as many as apply. And while you do that, I'm going to take a minute to introduce you to the affordable Clarius HD3. Now, this is our third generation of portable ultrasound scanners. Together with artificial intelligence, Clarius scanners deliver the image quality only found on traditional ultrasound systems, but at a fraction of the cost. You're looking at about an 85% savings. So with AI replacing complex knobs and buttons, it's as easy to use as your smartphone. So you can quickly diagnose MSK injuries and guide management if you're doing that procedural type of procedure. Clarius scanners are also Clarius are also safe for ultrasound guided procedures like PRP injections, as well as dry needling, if that's part of your practice as well. And Clarius is wireless, as you saw. So you can free up space with zero footprint, ultra portability in a variety of settings and patient positions. You get free movement with no wires getting in the way. So you can position your patient however you want. Only Clarius delivers wireless scanners with an ecosystem that includes a free app for your iOS or Android devices for unlimited users. Available with our membership, Clarius Cloud is used to easily capture and manage unlimited exams from anywhere. It's a great tool for saving images, especially if you're following a patient with serial studies. Your membership also includes in-app Clarius classroom videos and onboarding with a Clarius clinician to build your skills. Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. And with your membership, you also get our advanced features that include dedicated presets and Bladder AI, voice controls, and a few other features that Janae showed you today. Good, so we have quite a few questions. We'll try to get to as many as we can. And if we don't answer all of your questions, we'll follow up by email in the coming days. All right. So one of the questions here, Adrienne, is how much is ultrasound is effective for female pelvic, and is there any side effect, especially in pregnant females?
So, and in terms of can we use this in pregnancy, is that?
Yeah, I think that's the main. I think it's asking for, how valuable it is. How often do you use this for pelvic floor assessments? And yeah, are there any side effects?
So I use it very frequently in my pelvic floor assessments, and I often use it as again a platter of options for my clients in terms of what type of assessment they want, understanding that the gold standard for a pelvic floor assessment is an internal assessment, and depending on what they're coming in for, so that can be a varied range of incontinence to prolapse to pelvic pain, to prep for birth, to postnatal rehab, lots of different reasons for coming in. So that's where, again, a tailored assessment and treatment would be catered to that individual, and based on what they also want to come out of that session with, ultrasound could be a part of that. Yeah.
Great. Can you explain how you instruct a patient to engage pelvic floor contraction when you are testing?
Sure. So one of the best cues that's been shown to translate onto ultrasound is more of a puborectalis cue. So again, that idea of squeezing the anus or holding wind, something to that effect. So that creates the forward and upward motion of the puborectalis, which is what we're kind of imaging again on a transverse view there. So that would be the best cue to observe that.
All right. Someone is asking, how accurate is this with morbidly obese patients?
So it can be more difficult to image with a greater abdominal circumference. So that's where, again, the curvilinear probe, it does have better depth penetration, but still can be difficult with significantly high obesity, yeah, and abdominal girth.
Right.
Yeah.
Okay, there was one question about identifying the abdominal wall layer. So hopefully we did that in the live demo. There's one question: when assessing pelvic floor muscles, are there any standardized measurements obtained to use in monitoring progress, or is it a subjective assessment?
So there's been some looking at the the bladder-based displacement. So to do that, you would really have to do some analysis at the end with creating markers and looking at the amount of movement of the bladder base. So in clinical practice, I don't typically do that. We're just looking for generally the quality of the contraction. So again, looking at the symmetry of the contraction, the symmetry of the relaxation, the completion or lack of completion of the relaxation, and then depending on again what the client's coming in with. So in the cases of the videos that we looked at the ability for them to hold an endurance hold, so be able to hold that pelvic floor. And some people may not be able to hold it for more than a couple seconds, and some people can hold it for 30 seconds. Not usually looking at a 30-second hold, but just to give an idea of what do they need to be able to do, why do they need that endurance, and what does it need to translate into, versus looking at the coordination of the pelvic floor, so their voluntary control of being able to contract and relax more quickly, which can be important when there is leaking with a cough or a sneeze or something like that, where they have to voluntarily bring on their pelvic floor.
All right. There's a couple of questions in here about the bladder volume calculation and the correction factor that's used. In the Clarius app, you can decide on which one that you want to use. So if your bladder is spherical, you can select the 0.52. If it's more ellipsoid, there's a 0.81. Unknown, kind of can't decide, it's 0.72. So yeah, you have 5 different options in the app. So that's something that you can determine on your own to calculate the bladder volume.
I was also taught with bladder volumes and PVRs too, to also have, so if we're gonna measure and then we're going to remeasure a PVR to measure the bladder output, so have them go urinate, but actually have them have that measured so that we can compare our measurement on the ultrasound to what they voided, and if that's coming up as also, correct, or if there's any discrepancies. Yeah.
Great. Okay. Let me see here. Is there a standard measure or ratio for IO to transversus abdominis girth that you're aware of?
So transverse abdominis should be about half the girth of the internal oblique. Roughly, it's always going to be a lesser girth than those, obviously those bigger movers, the internal and external obliques. So we're looking at more of a postural muscle. So not gonna, when you see a skinny transverse abdominis, it's not a bad thing, but the typical ratio is about that.
All right, we are just about at the top of the hour here. I think a lot of these are, there's a lot of pricing questions about Clarius and questions about the app and functionality. I will follow up with you in the coming days on those. Other than that, I think we are, to be respectful of everyone's time, we are at the top of the hour here. So thank you all for your questions. on our Clarius website in the education tab, you'll find a lot of Adrienne's classroom videos that she showed today with little explanations, and they'll have voiceovers on them. And just a reminder that you'll all receive a PDF copy of the slides and a webinar recording of today's session. Thank you so much, Adrienne, for sharing your best practices. And again, a very big thank you to all of you for joining us. Until then, keep scanning and have a wonderful rest of your day. Bye-bye.